two quick more things with HER2 before we move on. The first, well, actually three things. The first is, what do people think about HER2 activating mutations? You think it's going to be an important issue? Because there is data actually with Neratinib that when you have a mutation in the HER2 kinase domain, that seems to be activating, that Neratinib, at least in this phase 1 basket trial that they're doing, seems to have activity. Do people think that it's going to be an important thing to look at going forward?
Absolutely. Absolutely. And that's one thing actually that you can also pick up in a liquid biopsy.
Right. There we go.
So the important thing also for people to realize is that these mutations happen in patients that are HER2 negative.
Right. That's
They're not
very
amplified.
important to understand.
So this is another mechanism by which cancers absorb that HER2 locus and mutate it for a gain of function. Many of these mutations are activating, not all of them.
Right.
And we now have data that some of them are drivers in that they respond very well to Neratinib, which to me is a sort of a clinical proof of concept, that they're driving the cancer at some level. So no, I think they're real. I think that not all mutations are going to be equally sensitive to Neratinib or to other irreversible inhibitors of HER2. There may be tumors like non-breast cancers where the response may not be as great, just because these cancers may occur in tumors that are a lot more complex and may not respond to single-agent Neratinib. In those, we would have to think of combinations. And in fact, in the breast cancers that are ER-positive, the majority of these mutations occur in ER-positive tumors. The combination with fulvestrant is showing great, interesting activity.
My understanding and seeing some data that I've seen is that lobular cancers, for some reason, may seem to have an increased incidence of HER2
27% in the clinical cancer research
Really?
Jeffrey Ross paper.
Really?
And this is unlike the ESR1 mutations. This is one of the things that I go after in the metastatic, even and especially in my practice, the lobulars in the peritoneum. The lobulars were highlighted in the clinical cancer research Jeff Ross paper. 27% of metastatic invasive lobulars, either activating mutations or amplicons or a few truncations. I find that they respond in the metastatic setting to anti-HER2 based therapies. Although it's really interesting, the fulvestrant Neratinib sounds really intriguing, but I'm also getting coverage for anti-HER2 based therapies, even for these for these activating mutations. But you also find amplicons. But the lobulars in particular are highlighted. They're in ductals as well, however, but I will actually, if I need to go to general anesthesia to get a good peritoneal biopsy, and I've never done that before, because you can't really do safely CT guided biopsies too easily if the peritoneum get enough tissue. But I find them not infrequently.
So instead of biopsying, would you then do a liquid biopsy?
I've done that, but I'm having a hard time interpreting what these teensy little percentage, it'll come back 0.6% of the cell-free DNA is a HER2 mutation. I'm like, I'm not sure what that means.
I think the important point for the practicing clinician is you have to do the testing on the metastatic sample. So I see a lot of people sending either the primary because they don't rebiopsy or the first recurrence core. And then the other important point is some of these mutations will be missed on some of the more widely available commercial assays.
Right.
So if you really are interested in this, you either have to do comprehensive exome sequencing through a commercial vendor, or you need to enroll a patient, which there's plenty out there for the full sequencing of the HER2.
That's a very important point.
Yeah.
In fact, some commercial vendors report some of these mutations as variants of unknown significance.
Yeah.
Right.
Doesn't mean they don't have significance,
Right.
because they don't occur necessarily in the same spot. So we're discovering some of these reading
unknown
errors.
significance of people
Correct.
interpreting them, but they're significant to the patient.
And patients
Right.
colleagues are throwing them away in some cases. And in fact, we're finding that some of these variants do, in fact, make patients qualify for enrollment in some of these basket trials.
So one of my colleagues' patients actually had a patient in that situation. She's one of the durable responders on the single-agent Neratinib study.
Really?
So I think we just got to be educated about what a mutation is, and really, so the point being is there's lots of clinical trials where full sequencing is made available, and
for many genes, we are in the learning phase.
Yeah.
That's the truth of the matter.
I agree.
Yeah.
But again, my own suspicion for the practicing clinician is probably going to be getting better liquid biopsy technology, because that seems to be an easy thing to do. You can draw someone's blood. You don't have to worry about doing peritoneal biopsy under general anesthesia. I suspect, at least in my opinion, I don't know what other people think, but I suspect that's where we're going.
We are going there. I think we have to be very careful of generalizing the approach. I believe that to be able to screen most somatic alterations that are actionable in a liquid biopsy would be great progress. Amplifications, we're not there yet.
Right.
Fusions, we're not there
I
yet.
agree. We need better technology
single
for that.
nucleotide variants, mutations, yes.
Yes, I agree.
So I forgot what I was going to say also about that, but I'll remember later maybe. But,
So one last.
this is what I was going to say.
Yeah.
In the SOPHIA trial, the mutations in ER correlated with a shorter PFS of patients on exemestane.
Okay.
And what was fascinating is that regardless of the abundance, the allele frequency and the abundance, the percent that mutation was in the total tumor DNA, regardless of that, itty bitty or huge, the impact was the same.
Because it means you had a clone that was resistant that eventually would do something.
And it's really interesting to add to that, Carlos, when we were talking about the ESR mutations data that was presented yesterday, they were able to predict 4 months earlier that these patients will progress by the occurrence of those mutations early on. So, to your point, if you can actually identify these patients early and project how they're going to be doing, whether you then need to start monitoring these patients more closely to make those treatment decisions earlier, may be very helpful. But I think, there needs to be some kind of serial, user-friendly component for us to be able to gauge treatment evolution, treatment resistance. And I think, liquid biopsies are there, but we're not there yet.
Right.
But that's the way we're going to get there.